Welcome once again into the Radiopedia Reading Room, a podcast unconcerned with books or poetry, tea leaves or palmistry. This is a radiology podcast. My name is Andrew Dixon, and joining me, old black blood himself, it's my co-host Frank Gaylard.
Oh, yuck. Black blood always makes me think of, I guess, either a pirate or some disgusting British blood sausage or black pudding or something.
Yes, a cantankerous pirate was what I was going for, but I feel like now you've mentioned meat, you're steering us towards your number one topic of interest, which is meat.
Funnily enough, Dixon, I do have a fake meat-related update for you today.
I never would have doubted it, mate. I never would have doubted it. So for listeners, new listeners to the podcast, this is a thing that Frank does from time to time. He updates us on the status of fake meat around the world. We oblige him. Sometimes Murph edits him, but we generally allow it as long as it's quick and genuinely of interest. This is, after all, I remind you, Frank, a radiology podcast.
Sure. I never go off on random tangents, so I think you'll be fine. This will be very quick. Okay, so before I get into it, I think we need a little bit of background here, because when we discuss the word fake meat, I think it's important to distinguish between meat substitutes that are usually plant-based products, made out of soy, but it could include like plant-derived heme to give it a bit of a meaty taste, versus cultured meat, which are animal muscle cells grown in big silver bioreactors or something. Anyway, meat substitutes, they've been around for, a decade, I guess even longer, because the humble veggie burger is kind of a meat substitute, but doesn't really try to be meat-like. But ones that try and mimic meat have been around for about 10 years. And they're growing, but they haven't made much inroads, really. They're a tiny fraction of the meat market, probably because they just don't taste very good. I mean, we've both tried them. I've tried a number. I'd love to eat not dead animal-derived mince, for example. But, it's just kind of weird. And I guess the other side of it is they are a new sort of technology. They're not using... Well, the veggie burger is old stuff, but like these soy-derived proteins that are made to taste like meat, we don't really know what's in them. It's probably all fine, but there's an element of me that thinks, maybe you'll find out something horrible. Everyone will get breast cancer or something. But anyway, lab-grown meat, on the other hand, that's much newer. That's very recent technology. Singapore was the first country to make it legal in only 2020. And followed by the USA in 2023. And now our very own beloved Australia is the third country in the world to make lab-grown meat legal. Specifically, one company that's actually based in Sydney called VOW, V-O-W, which is the same company that made the meatball from cultured mammoth meat, which I think we spoke about like a year ago or more. Anyway, the mammoth meat is not available to eat. Boo. I'd love to eat extinct animals, but they're worried that somehow it would harm us. I don't know. Anyway, the one product that now is legal is, and in lots of restaurants in Singapore, is lab-grown Japanese-style quail foie gras. And I think this is cunning and excellent. One, because foie gras tastes delicious. And mostly because also you don't eat it that often and you don't really know what it exactly should be like. So I don't think you can compare it as easily as you do with a steak or mince. But also, foie gras is pretty homogeneous in texture. So it's probably better suited to something that is grown in vats. Isn't that disgusting? The word vat just does not sound very appealing.
Not a good term. They should think of something better than that.
But the third thing, and I think probably this is the one that is most important in some ways, is if you know anything about how foie gras is made, it's just hideous. Like even by the extremely low standards of animal welfare that we have in the meat industry, foie gras is just disgusting. And so I never eat it as a result. But I'm very much looking forward to wherever the first Melbourne restaurant to have this lab-grown foie gras. I'm going to be there on a nice piece of toasted brioche, I'm sure is just divine.
Yeah, count me in. I'd be very much up for that restaurant experience for sure. It's the perfect choice for the first kind of lab grown meat, isn't it? Because it has
Yeah.
so many elements to why it works. But to get us back on course, Gaylard, sticking with the maritime theme, I said black blood in the intro, not because I wanted to talk about meat or pirates for that matter, but because today's main segment is a neurovascular MRI discussion. You recorded at last year's Radiopedia conference with the one and only Christine Glastonbury. And one of the major things you chat about is vessel wall imaging, which involves black blood techniques to ensure the flowing blood in the lumen stays black so you can see the wall, enhancing and only the wall.
Yes. That was a really good session, actually. I had a lot of fun chatting to Christine. I mean, I always have a lot of fun chatting to Christine. She's such a fabulous radiologist and a great teacher. And we get to kind of nerd out and grumble about things that annoy us as well.
Yeah, she is great. And in fact, I'm going to record an hour-long panel discussion with her for the conference later this month on parathyroid adenoma imaging, which will also eventually feature on this podcast, Gaylard. So, quick reminder, in case
Yes.
anyone is unaware, the conference is almost upon us. It's fully virtual, so all online. It runs from July 21 to 25. 30 live sessions are being streamed out, one commencing every 4 hours over the 5 days. Then for all access pass holders, there's 120 days of post-event on-demand access to it all. So you don't have to stay up 24 hours a day and watch it all live. Frank, you're doing many things for the conference, including a neuroradiology case workshop with Lee Al-Halali and an interactive The Final Scroll session with me on the last day.
Yeah, so many things, Dixon, so many. Although, to be honest, it feels more and more like you just wheel me out and point me in the right direction and give me a shove and off I go. You are increasingly the puppet master and I am merely the puppet.
I prefer to call you a Muppet, but close enough. Anyway, we better jump into the main segment now. So, Frank Gaylard chatting with Professor Christine Glastonbury, a neuroradiologist at UCSF. We'll listen in, and then the Muppet and I will be back to have another chat in the outro.
I'm now joined by Christine Glastonbury. Welcome, Christine. Great to see you again.
Hi, Frank. It's great to see you too. Thanks for inviting me back. I can't believe you wanted to do another round discussing neuro.
It's always a pleasure. And basically, that's all I want to talk about these days, if radiology at all. So never get enough. And I wanted to take this opportunity to talk to you, not just about vessel wall imaging specifically, but about vascular imaging on MRI more generally, routine imaging, as well as vessel wall imaging, and pick your brains about a whole bunch of little questions that I have about my own practice.
Sure. Sounds really good.
The first question I have for you is, what do you see the role of MR in cranial vascular imaging compared to, say, angiography or CT?
Okay. So I think everywhere, not just in the US, but everywhere around the world, everybody's talking a whole lot more about radiation and risks of radiation. So I think MR always offers overdoing CTA, the ability to not radiate somebody. So just as a kind of baseline, if you have an option, if you're just doing a screening study, and particularly in a younger patient, I'm always going to start talking about we should probably be doing MR/MRA for imaging. And I mean, a CT is a really good study for the brain, but there are so many other things that might be going on with a patient that an MR with an MRA to me is such a kind of complete package study to get a good imaging of the brain, good imaging of the vessels, rather than starting with a radiation sort of study like CT.
That's a very US answer, isn't it?
It is,
Because
isn't it?
it's
I know.
predicated upon
I know.
easy access to MR. And
Relatively,
unfortunately,
yes.
not everywhere is as fortunate as the US, and to a lesser degree, Australia, although I think our access to MR is improving. And I guess in the older population, radiation is much less of an issue. So from a stroke workup, CT seems like a pretty reasonable approach.
Oh, more than reasonable. CT, CTA, quick, fast, you get your answer, you know what's going on. We're still doing CT perfusion, even though, there's a lot of kind of conflicting evidence about really the value of that in many patients. But one of the things that I like to think about when I'm looking at CTA images, and also with MRA as well, is not just to look at those source images or the 2D reformats, but I always 3D reformat all of my CTA studies to look at the intracranial vessels. I want to recommend that to all the trainees who are listening to that. If you can do that on your packs, if you can take a look at 3D, you're going to pick up a whole lot of areas of stenoses and potential aneurysms that are really easy to miss on the 2D or just the source images.
Yeah, I have exactly the same habit. I always look at whether it's MRA or CTA in a 3D environment where I can rotate the volume. In fact, we've upgraded our packs, and upgraded is inverted commas because the NPR functionality has been degraded. It used to be fantastic that you could just pick a center of rotation for the structure and then rotate the volume. And then you can pick each vessel which plane is best seen. And I typically use a MIP of about 3 to 4 millimeters when looking at both. But now it's made it a bit harder. So, but yes, 3D definitely, because each vessel has a particular plane that it's best seen in, right? And it makes your life so much more easy if you can put it an oblique coronal for the basilar and you can see it beautifully branching. There's no way anything is hiding in there instead of looking at a dot that's changing caliber as you scroll in and out.
No question. And that's something when I'm reading out with trainees, and I keep saying this, and they look at me like, oh, here she goes again, because I have a few, finicky things when I read out, little OCD. And then you have a case like that, and suddenly you can see the stenosis of a distal MCA that you really couldn't pick up before. And you're like, or the PCAs classically, because they undulate in and out of the plane.
And that's where the ability to have a MIP really helps as well, to look at length of vessel rather than a dot.
Right, exactly. Yeah. So I think that's important with all vascular imaging. Don't just use the source images.
Okay, so when talking about routine MR vascular imaging, so a study, say, for looking at an AVM or an AVF, what do you think goes into that routine study?
So we have pretty set protocols for things like that. With every sort of vascular imaging, we always have a routine brain. And so flare, diffusion, T2 weighted imaging. We do, and T1, we do our flares as 3D flares, which I love. I love being able to look at it in multiple planes. I realize that some people may not. It looks really nice to me and you don't get any flare artifacts. So
I'm torn with 3D flare because
really? What's the controversy?
2D flare just looks so much cleaner than the 3Ds we have. And particularly for tumor, I think you can see like cortical involvement more easily on a standard 2D flare than the 3D, to the point, and this is not really my decision, but our department as a whole kind of feels this way. For our glioma protocols, we run both the 2D flare and the 3D flare.
Oh, interesting. Yeah.
Because of that reason. But I agree, like the advantage of 3D almost always outweighs any of the downsides of the increased granularity and the poorer signal to noise. That ability to reconstruct is so important.
Yeah.
Okay, sorry, derailed you.
No, I know we kind of went off plane here a little bit, but like with demyelinating lesions, I love the 3D. I'm always picking up more disease. Yeah. Okay, so start with a routine brain study. And we have on a time of flight MRA would be our routine sequence. And we do, to cover the circle of Willis. Now, if we are doing a study for somebody who has pulsatile tinnitus, we actually extend the field of view for our time of flight. And we do it from C5 through the circle of Willis. And it fits in the carotid bifurcation on that sequence.
Oh, that's a great
without having to do a separate MRA of the neck. It works best on a 3T, but you can do it on a 1.5T magnet. But it just gives you a little bigger coverage, so you get the carotid bifurcation through the circle of Willis. And then for most patients, if there is a suspected vascular malformation, dural arterial venous malformation, we're going to do a contrast enhanced study, a TRIX. We use mainly GE scanners, so we're using TRIX for that.
And how useful do you find the time resolved? Because I always feel like the acronym time resolved is You get one pre-contrast, you get one that's kind of got some arterial and venous, and then you get 1,000 venous sequences.
Well, you've got a point there. So there's some truth to that. I wouldn't say 1,000, but it's close. So the way to look at those for me is to look at them backwards. So
Yes.
rather than looking from arterial to venous, look at, which was the way I was taught to look at angiograms too,
Same.
catheter angiograms.
Yeah.
Look at the venous and go backwards, and you're looking for that early venous enhancement that would suggest that you've got some sort of fistulous communication going on. But I do the same thing with those. I think that's really funny. Sorry. But I also try and 3D reformat the best sequence out of that as well, out of the arterial phase there.
Speaking of the venous size of things, just in general, if you need to look for a venous abnormality, whether it's a dural venous sinus thrombosis or a cortical venous thrombosis, and you could only have one test, would you do a CT venogram or an MR venogram?
God, that's a tough one. Well, if I really thought it might be a cortical vein, I'm going to go with an MR, not a CT.
Because of the ability to visualize the veins, or because you get to see the parenchymal changes that are associated with it?
Both together.
Yeah.
I think you've got an improved chance of suspecting exactly where it is because of the parenchymal changes. But also, I think with the calvarium, when you're trying to get things in it, you've got no issue with the calvarium. You can really see detail of the small cortical veins, in my mind, with a post-contrast. So the 3D SBGR is really nice, but we have a complex protocol when you suspect venous thrombosis. I'm not a big fan of the MRV unless you're doing a post-contrast MRV as well. I know our clinicians always say, oh, we need an MRV because we're looking for venous thrombosis. And I'm like, if you just have that, you're not going to know anything. So I really like the post-contrast 3D spoiled gradient T1.
Yeah. It's funny, isn't it? Because I think in medicine in general, and definitely in radiology, we sometimes have these ideas about what the best way of imaging something is based on literature and developments from 30, 40 years ago. And MRV, in terms of phase contrast particularly, feels like one of those, because when it first came out, it was, oh my God, for the first time we can look at veins without doing a venogram with a catheter or an angiogram. So MRV became the gold standard. But really, it's a rubbish test most of the time. And I'd prefer to look at a post-contrast T1 MP rage to assess the veins
Every day
than any MRV. Really, the phase contrast MRV is purely to answer the question of, is there flow in this particular region when I can't assess it on the basis of contrast?
it is.
And maybe an example would be a highly vascular tumor like a meningioma, where you're not certain whether what you're looking at is tumor or contrast, although almost always you can sort that out anyway.
You can sort that out, or you can put in a cube T1 where the veins become black. And that's helpful if you think, when you have a meningioma up against a vein, that's a really helpful if you suspect that, to use the cube T1. And if you're using an MP rage and SBGR, the veins are always enhancing with contrast, but not with a cube T1. So that's one of the tricks that I would use. You mentioned the protocol, and I kind of got distracted again. Back to the other thing that we have added to all of our routine brain protocols, especially if you suspect anything vascular, is using arterial spin labeling.
Oh, you do that routinely?
We do that now routinely on our scans. And it's magical, especially if you're doing like someone who has pulsatile tinnitus again, and you're looking for really subtle things. I think it's a really magical sequence. It also increases your degree of confidence that there is no shunting.
So what sort of things do you end up picking up there, in particularly in that setting of pulsatile tinnitus? How does ASL help you?
Well, so the most common cause of PT is just idiopathic intracranial hypertension. So ASL is not helpful for that, right? Your post-contrast and everything, look at the cellar, look at transverse sinuses, you're done, easy. But if you've got really subtle dural arteriovenous malformations, things around the skull base like that, absolutely magical.
Okay.
I really love it.
That's really interesting.
Yeah.
Okay. Now, before we go into vessel wall imaging, which I think is where I want to kind of dig down into a little bit before, I wanted to ask a few quick fire questions.
Uh-oh.
because I wonder about these quite a bit. I see a lot of variability in how others do it. I have some opinions, but I'm not sure that I'm right. So I don't ask this at parties, really, but it's a go-to question. So first one, when you're reporting an MRA or a CTA and you see an infundibulum. Now, this is not one of those where you're like, oh, this could be an aneurysm. This is like, no, I know this is an infundibulum. I can see the vessel coming out of the top. It's conical. It's in a place where I'm used to seeing it, say PCOM or anterior choroidal or whatever. What do you do with them? Do you report them? Do you ask for follow-up? Do you make sure they don't get follow-up? Or do you just ignore them?
Okay. If I feel really confident about it, then I say this is an infundibulum and does not require follow-up.
Mhm.
If I don't feel confident, that's the problem. And that's where I'll say, consider a follow-up imaging study.
Yeah.
A repeat imaging study. For example, if we've done the study on a 1.5 TMR and you're just not feeling that degree of confidence, then I would say recommend 3T follow-up MRI.
Yeah.
But if I feel confident, I usually say I see it and move on. But part of the reason I say I see it and move on is because I'm reading out with a trainee.
Yeah.
And the trainee's seen something. And now that you've seen something, you kind of have to explain it. If I'm reading on my own and I'd see it, I feel like if I felt really confident, I might not even mention it. I might just move on and just keep going.
Yeah, I feel very similar. I think for me, the first question is someone else going to see it and get confused? Because if it's something that I think, and this happens with, say, pineal cysts or all sorts of little incidental findings, even though I know 100% this is a infundibulum, say, that doesn't need follow-up, I worry that someone might see it and think, not that I missed it, but think that it is an aneurysm and then act on it. And so whenever there's a finding that I think someone else, and when I say someone else, I don't mean another radiologist, because I'm happy for them to see it, but like the clinician, the GP, whatever, and then misinterprets it and then says to the patient, oh my God, there's this big white thing in the middle of your head. It's a cyst. It might be a tumor. It's like, no, I need
Right.
to say that. But I do worry about giving people labels, because we encounter so many patients that get fixated on a thing, a cyst, an infundibulum, a DVA, all these little things, and it can ruin their life, because then they go online and they find some support forum
Mm-hmm.
for people whose lives have been ruined by, and the classic ones are Tarlov cysts, Chiari-1 malformations, and a lot of this is just doing harm. It sentences patients to be anxious and to seek, repeated remedies, sometimes from people who have dubious motivations when it comes to, alternative or non-clinical medicine. So if at all, I try and avoid mentioning these things personally, and I'm kind of happy to take the bullet for that. But I think what I'm doing more and more is being explicit about saying this does not need follow-up. And when you start doing that, it's really confronting, right? Because it's not something radiologists feel very comfortable doing, a lot of people. But I think that's really important for us to say, this is fine. Do not follow this up. All right, good. So we're on the same page about that one.
Yeah. And I think you've hit the nail on the head, that balance between patients, other people reading your reports. All patients in America can now read their own reports, the entire report, whenever they want, and balancing it with doing the right thing. But I like that recommendation. If you're going to mention something, tell them what to do with it.
Yeah.
Like same thing with thyroid nodules. If you don't want anything done with it, don't mention it. Just move on. Yeah.
Okay. So in a similar vein, when you're looking at a non-contrast MR, and you see usually it's T2, I think you see it best, but you see a DVA, a developmental venous anomaly. In your heart of hearts, that's what it is. What do you do there? Do you call them back for contrast? Do you do
no.
You just, do you mention it again, incidental DVA, and move on?
Yep.
Good.
Incidental DVA does not require. So I would not call them back for further imaging. If I've looked at that and you've seen it, and of course we use susceptibility weighted imaging on every routine brain. So you see them, all the time.
Yeah.
Does not require further follow-up.
What about cavernomas?
See, that's a different thing. I would mention in the body report. I don't usually mention specifically follow-up for that in a report. I can send a quick message to someone, say, this is an incidental cavernoma, a quick 2 sentences to explain this doesn't necessarily require follow-up. They may want a consultation with a neurosurgeon, knowing that if you send someone to a neurosurgeon, they may end up with surgery. So,
Well, and they'll end up with lifelong follow-up studies. We do a lot of cavernoma follow-up studies on asymptomatic people that have never had a leak. Not only that, but it's actually quite hard to convince others, particularly the surgeons, to not ask for an AVM protocol with contrast and time of flight. I mean, realistically, if you're really worried, you could just do flare. Just one slice through the cavernoma, and that's it. Has it changed?
You need to write an editorial about this somewhere, because I think this is a really good topic. What is the point? What is the point of follow-up imaging in something? Unless you're talking like there's a brainstem lesion, this could be critical. Most of them, there's nothing anybody's going to do unless they bleed, more. And
I think sometimes the point is that it gives the doctor something to say at the outpatient appointment visit and makes it quicker, because they could say, oh, you've had your scan, it hasn't changed, great, you're feeling well, good, bye. And that's a faster discussion. But why we're doing any of that, really, because we're going off on a tangent here, but there are lots of conditions where the risk of that thing doing something bad is so similar to a random person that you've never seen having something bad happen to them, that you really have to ask the question, why aren't we kidnapping people off the street with a black van and taking them to outpatient clinics randomly, if what we're doing is following up a 1 centimeter asymptomatic cavernoma in someone that's never had a bleed and never had a seizure? You've probably got more chance of finding something unexpected and useful in someone who's never had a scan than in someone who's had a scan and the only thing they've got is a cavernoma, because then you know that they don't have a tumor, they don't have an aneurysm, they don't have all of these other things. Whereas someone who's never been imaged could have some of those, and the risk is probably higher in them.
Absolutely. You're achieving nothing and you're giving them some false sense of security that you've imaged it, it didn't do anything. That doesn't mean it's not going to do anything in the future. But scanning them is not going to prevent anything happening. It's not going to fix anything. I agree. Waste of time.
It's a false sense of security, or perhaps even worse, an ongoing anxiety because they've got a vascular malformation.
Absolutely. No, you're correct.
Now that we've gotten these little bugbears out of the way, let's get into vessel wall imaging, which I think for many is confusing and a bit of a magic bullet in the eye of some clinicians. And when there was the first, I guess now it's 5-10 years ago, when the first sort of vessel wall imaging became popular, it was seen as whenever we're confused clinically, let's order that test because it'll come up. And one of the problems is that vasculitis is so heterogeneous in how it presents, both clinically and on imaging, that it's very hard for us to ever say this patient doesn't have CNS vasculitis. And therefore, it's like, well, then let's do vessel wall imaging. So before we begin that, when do you think we should do it? And do you do it as part of an initial study, or do you always do it as a follow-up after they've had routine brain imaging?
Never as an initial. The only time we would do it as an initial is not intracranial vessel wall imaging, but is giant cell arteritis sort of style. When you're looking at the superficial temporal arteries, you have a very specific target. Yep. But for intracranial arterial vessel wall imaging, we would never start out with that. So when this first came out, and you're right, it's about 10 years ago, that it seemed really exciting. And I was really excited about, this is amazing. And then the number of pitfalls with this, the complexity of doing really good imaging, like getting really good flow suppression, CSF suppression, beautiful high resolution imaging, number one. That's the easy part, it turns out. That the interpretation can be so complex and there are so many pitfalls. And when you look at the protocols of places of people who do it really, really well, they're not easy protocols. No one should be starting out with vessel
Mm.
wall imaging, I think, as a starting point. And for us now, a vessel wall imaging study is done after we've done routine imaging, which, as I said, for us is already a 3D flare T1, diffusion, susceptibility, arterial spin labeling, and T2. You've already got really good whole brain imaging. And it's only then when the question has come into, is this vasculitis or is it reversible cerebral vasoconstriction syndrome sort of thing? Do you think there is some sort of plaque in the MCA or the cavernous carotid that's causative? It's really a problem-solving tool. And then
I see it
you're going to spend the time.
It's at the time that you are considering putting a catheter in or doing a biopsy. It's one of those, I don't know what line, second, third, fourth line investigation that comes after MDM meetings, multidisciplinary meetings and consultation, and you're really trying to sort it out. It's not a let's have a look and see.
100%. It is not. And they take so long to interpret well too, that you don't want to be doing it for everybody who comes in. But yeah, it really is a multidisciplinary. They've usually had CSF done as well, and you've got all these inflammatory markers, blah, blah, blah. And we're trying to hone down to be really defining a very complex problem. It's not a run-of-the-mill sort of, let's just order arterial wall imaging.
Yeah. Now let's dive into a little bit the specifics of how you do vessel wall imaging, particularly how you get black blood sequences and field of view resolution, etc. What's your take on the best practice there?
The protocol that we have, and again, to clarify if anybody misheard this, it's truly done as a problem solving after we have a dedicated brain MR with good evaluation of everything. And it is before anybody's done a catheter angiogram. We use a 16 centimeter field of view. It is a T1 weighted. We do a 3D T1 weighted, and we do ours in the sagittal plane. And we're looking at 0.6 millimeter contiguous. So you end up with really beautiful isotropic voxels for this. We reformat them in the axial and the coronal plane, and we do that pre-contrast, and we also do it post-contrast, and we don't do fat sat on our post-contrast for our intracranial arterial wall imaging. But we do that again with pre and post GAD, no fat sat. With the technologists, you're trying to get them to center the 3D volume between the pituitary and the pons.
Yes.
That's the middle of your field of view when you're doing it. And that gives you, with a 16 centimeter, that gives you a really good look at the circle of Willis and the important vessels that you really need to be focusing on, as well as giving you high enough to see some peripheral M2, M3 branches.
There's such beautiful studies when they're done well. It's the kind of study that you kind of wish you had all the time. And realistically, I think with the speed at which MR image quality has improved over the past decade, it's probably not unreasonable to think that in 10 years' time, our routine T1 MP rage is going to be kind of like that. But the detail that you can see in surrounding structures, and particularly the pituitary, for example, it's just gorgeous.
Beautiful. So interestingly, we've actually used that same SAG T1 3D, except we use fat sat on the post contrast when we do our IAC, our temporal bone MRs now. We use exactly the same protocol, except with fat sat post contrast. The resolution is gorgeous. It's just a beautiful way to look at the internal auditory canals and the basal cisterns. It's stunning. It is really pretty.
Yeah, it is. There's a slide that I use when talking about mesial temporal sclerosis, where I have a really good quality T2 small field of view through the hippocampus in a patient that then went on to have a mesial temporal resection, an amygdala hippocampectomy. And I've got the large field of view histology slide of that person's hippocampus next to it, where you can see the individual cell bodies stained. And you get a sense of, you know what, we're not that far away.
I know, it's scary, isn't it?
It's like, when we're looking at it, it's not billions of cells in this image. It's like, no, that little CA1 stripe in the hippocampus is like 10, 20 cells, and there's the histology. And I think it's going to be very exciting when we can put pathologists out of business.
Yeah. I'm not sure that's happening very fast, but
No,
no,
it's
but
if
it is.
anything, it's going the other way, because molecular markers are becoming so much more important that how things look under the microscope is less relevant than it used to
Right.
be.
The other detail, if people are listening for that protocol, only on a 3T, by the way. We don't do any vessel wall imaging on 1.5 Tesla. You're not going to get the resolution that you need.
Well, and I think actually that's an important point, because it's not just that you will get a study that's not very good. You will actually get a study that you may misinterpret, and that if you misinterpret a vasculitis study and say, oh, this could be vasculitis, and the neurologist or immunologist or whoever believes you, the treatment for that is not trivial. The drugs involved have very high side effects, and the last thing you want to do is take a patient who doesn't have vasculitis and subject them to the treatment as if they are. So it's really important to not be flippant about how you report these.
Right. And if it turns out it's not vasculitis, it's reversible cerebral vasoconstriction syndrome, the treatment is entirely different.
Exactly.
You've gone completely down the wrong direction.
So let's talk a little bit about the main features that you would look for in the main disease categories that we're using it for, recognizing, like with everything in life, that the things you see in a paper or a textbook make it seem really easy. But when you actually get in there, at least I find it extraordinarily hard the majority of the time. The times that it's really obvious is where you kind of know the answer already clinically. And when it's not clear clinically, then you're scratching your head. But let's just talk about ICAD, intracranial atherosclerotic disease, proper vasculitis, and different causes of spasm, and how you would distinguish those three from each other if the gods are smiling upon you.
Right. Well, if the gods are smiling. So I think one of the things that you mentioned before is about, is part of a multidisciplinary discussion. And I don't think you want to be interpreting any of these studies without really understanding what is going on with the patient. And it's very hard sometimes to separate what is it that I know to be true just from the imaging, and what do I know to be true from the imaging with the influence of understanding all the other factors. And by the way, when I was training, I remember people would say, clinicians would say, oh, I'm not going to give you the history. And I'm like,
Ugh.
this is not a test. Like, that drives
Pet.
me insane.
Pet hate.
We're going in the same direction. Okay. Like, let's work together. So it is complex. And by the way, that's how every neurologist works too. They're trying to piece together the radiology, the CSF, the serum markers, everything to get an answer. Well, I think it's the same interpreting these studies. You need to put together as much information as you can with them to put things in context and where you weight some of the findings. But when I'm looking at them, I want to have three things. I want my T1 pre, the T1 post. I want to be able to reformat them in multiple planes, and they come to me reformatted already. I want to actually be perpendicular to the carotid artery. So if, for example, the petrous carotid, my images come out sagittal, coronal, and axial, I need to actually be able to reformat that perpendicular to the petrous carotid. It's just how I'm going to look at it if I am looking for atherosclerosis.
But I mean, that's how coronary imaging has always, well, not always been done, but, CTA is done either along the vessel to see the pattern of stenosis, or at right angles to it. No one looks at it obliquely, which is how, if you don't do your own reformats, you're forced to look at them in MR or CT for that matter.
Right. So I definitely want to be able to manipulate the images the way I want to do it.
Yeah.
And to be able to look at particularly things like the petrous. That's important to me, to be able to fool around a little. And again, this is why interpreting them takes so much time. And I want to feel confident that what I'm not calling plaque. So for example, plaque is typically on these images, these black blood techniques. So the arterial flow is black. And what you're looking for is usually an eccentric kind of a deformity of the inner aspect of the lumen. Now, on a post-contrast study, the outer aspect, which we call the lipid part of the plaque, which is confusing to most trainees because lipid we think as being bright on T1, but these don't look particularly bright on T1. And on a post-contrast, they look relatively darker, and that's because it's mainly cholesterol. It's lipid's a really bad term. But then the overlying fibrous component is the part that's going to enhance. And you may see a little enhancement of the periphery of the wall, depending which part of the artery you're looking at. So the petrous carotid, for example, I'm going to see some enhancement of the wall, and I'm looking to see enhancement of the fibrous cap of the plaque. But deep to that, in that eccentric, that plaque is usually relatively low on T1 weighted images, the lipid component. So I want to look at the pre and post the deformity, and I will look for the enhancement. And I want to be perpendicular to that vessel. So if I'm going to do that for the petrous, and then I'm looking at the cavernous segment, you can see it takes time to go through the whole thing when you're looking at a vessel properly. So that's just looking for atherosclerosis. Similarly, I'm going to do the same with middle cerebral arteries, depending where the infarct is or where the perfusion abnormality is that I'm looking for stenosis in an area of plaque. Comparing that to vasculitis, it tends to be more circumferential, although athero, particularly in the vertebral arteries, tends to give you circumferential concentric enhancement too.
And you can get sort of more inflammatory ICAD as well, which again, this is like, it's meant to be so simple. And the tables show you 3 columns and what all the findings are, and then they all fall between them.
Right. If you're reading an article that says, here's the easy way to distinguish them, it means that those people don't know anything about actually doing the studies, because it is really complex sometimes. And the vertebrals are a classic that you can see concentric enhancement of the vertebrals. And that's actually also described as a normal aging phenomenon. And it's just the development of vasospasm. So
you basically see that, I guess it's probably 1 or 2 centimeters from where the vertebral arteries come through the dura, you get a cuff of calcification so frequently that it's not normal in that it's not normal, but it's so normal that it's like having osteophytes in your knee when you're 90. It's just that bit of vessel for some reason gets that. And there's, I guess, a real benefit to having CT alongside MR, because being able to see all that calcium in a typical pattern makes it a lot easier and doesn't get you confused about the enhancement or the MR appearance. Would you insist on having a CT or a CTA whenever you're looking at vessel wall imaging?
I don't, but I always like to have a time of flight MRA as well. One of the things I mentioned at the beginning, the pitfalls, is getting that really good flow suppression, which can mimic a plaque, an eccentric plaque, and particularly is problematic where the arteries are most tortuous. So classic petrous cavernous internal carotid is pretty tortuous, and you can end up with what looks like plaque, but is really it's just a slightly slower flow in one area. So having an MRA is a really useful way to say, oh, no, that's probably just flow because it looks perfect on the MRA. And for that reason, some people recommend that you do a post-contrast MRA as well, which we do not routinely do.
Yep. And now going back to vasculitis, we're going to try recognizing that it's really hard. What vasculitis should be doing is it should be wall thickening, concentric, and that the way that I talk about stenoses in arteries when I'm teaching trainees is that the word beading is used excessively. People use the word beading just to mean a number of focal stenoses. But to me, the word beading is very similar to what happens in the small bowel when it gets involved in lymphoma, where that infiltration of inflammatory cells causes the wall in some places to be thickened and stenosed because the wall is thickened. And in other places, the normal elastic structure of the vessel is compromised, so it actually balloons out. So to call it beading, in my mind, I need to see intermittent stenosis and dilatation. Otherwise, you just have multifocal stenosis, which is very different. Is that how you kind of think about it as well?
I never use the term beating. By the way, I also do not normally compare intracranial vessels to small bowel. So,
Neither do
but no,
I usually.
yeah. I don't use the term beating. I don't like it. I think it's something that is it's an old angiographic term that it should not be used. I mean, I don't think it's particularly helpful. I agree. I call multifocal stenoses or areas of dilatation, but I'm much more descriptive about what I actually see. But you're right that finding of thickening of the arterial wall is something that we're looking at. And, the arterial wall, like middle cerebral arteries, for example, we're talking it's like 0.2 millimeters thickness.
Yes.
And of course, that's unbelievably thin, but it's also, our voxel size, we're talking about, 0.6 millimeters. So our resolution, we're kind of borderline, but you can see areas of thickening of the wall with arterial wall imaging. And one of the things you're looking for is enhancement of those areas of thickening. So it's both thickening and enhancement. And, for differential diagnosis, that RCVS, that reversible cerebral vasoconstriction, you will see thickening of the wall, but you will not see enhancement, or you'll see minimal enhancement with that.
Well, you're seeing the same amount of enhancement as you would normally see in a vessel. It's just a bit brighter because it's squished down because it's stenosed, but there's no actual increase in enhancement.
Right. It's not an inflammatory enhancement around it.
Yeah.
Right.
And that would be the same in vasospasm post-subarachnoid. One, it's much more tapering and there's no real thickening, only the amount of thickening that you'd expect from the fact that it's contracted down.
Exactly. That it's contracted down.
There's no extra tissue there.
Exactly.
All right. So they're the three kind of main categories. I don't think we've missed any particular ones that usually come up. What do you think are the biggest traps? You've mentioned slow flow mimicking plaques, for example. Are there any other ones? Because I can think of one that has caused me great pains in the past, and that's that little comet tail flow phase artifact that you can get, particularly in the Sylvian fishes. Whenever the vessel is going sort of in plane, you can sometimes get a little streak of phase, which then can overlap the next vessel or make it look artifactually enhancing. And you don't notice until you reconstruct it and then see, oh, actually, that's all it is.
So that part of it is, again, looking at any abnormality that you think you can find in 3 planes and trying to look at that carefully. Some people recommend repeating, which is obviously, hard to get your patient back on the magnet to do this. If you think it is just that artifact, to do, instead of doing a sagittal plane for your black blood technique, do it in the coronal plane. And those things will disappear. But again, more time on the magnet. I mean, these are usually complicated patients you're doing it with. When you're looking at really peripheral vessels, when the question is vasculitis, do we see a small vessel that's worth biopsy? Right? We think this patient has vasculitis. That's one of the reasons we might do this technique. Can you recommend the best place for biopsy? And there are a number of papers saying this is good for that. I think it's really hard for that. But when you're looking at, am I actually seeing enhancement of the vessel wall, or am I really looking at leptomeningeal enhancement? Things like that I find extremely difficult. I'm zooming up the images as much as I can on the PACS. I'm putting it up with the flare as well to try and distinguish. So to me, that's a problem area. That's a pitfall, that it's really just leptomeningeal enhancement that I thought was vessel wall enhancement.
Well, Christine, I think we've been doing this for long enough, and I really wanted to thank you for spending this time and listening to my tangents and old man grumbles. But it sounds like we share quite a few of them.
Yeah, I've got old lady grumbles.
Thank you to Christine for joining Frank there. I actually helped Christine record her upcoming lecture for the conference this year, which is on post-radiation effects in the neck, Gaylard. And I learned at that time that she hates seeing herself on camera, but she's fantastic, very animated when she presents. So I forced her to record with her webcam on. So as opposed to previous years, her 2025 lecture includes her face.
That's excellent. I've noticed that about her previous lectures, and actually I was kind of disappointed that I couldn't see her speak because she speaks in such an animated way and it's great. I think actually for all lectures, and I don't really understand why this is the case, but to me, it makes such a big difference whether I can see the speaker. I think it's great that most of our lectures have the speaker's face next to it. It gives it, I don't know, it makes it more human. It improves my retention of what people are saying. Maybe it's all those small cues that you get from someone's face as they're talking about something.
Yeah.
But very happy to see Christine next to her lecture this year.
Yeah, as long as Craig Hacking remembers to put on his shirt, then yes, webcam is preferred. All right, getting back to this podcast episode, Gaylad, and the use of MRI for neurovascular imaging, I wrote down a few little things as I listened here. Firstly, PACS systems, MPRs.
Yes.
I don't want to mention any institution that I may or may not work for or any vendors specifically, but I feel like I'm working in the dark ages with what I'm given to use at work. Like, you might as well call me 2D standard planes only Dixon, you know. And this is coming from someone, Frank, who has an MRI sequence named after him.
Yes, of course. Definitely you.
Yeah, and I don't want to go into details about tenders for new PAC systems and how you would think that when there is a consensus after going through a methodical process about which is the best choice for your hospital, only to be told that another system, one that wasn't even on the tender, is the one that you're going to get. And it turns out, that one is pretty much the same that you already have. Well, you know, it makes a discussion like your one with Christine about obliques and MIPs and things like that a little bit hard to sit through, Gaylard.
Yeah, I'm sorry, Dixon. And that sounds rubbish, but I completely understand how that happens. Again, without mentioning any names, I have been having very similar discussions with a rep from our PACS, or APACS, I should say. And the poor guy had to sit there politely listening to me rant about how poor their product was and how I understand that it's not his fault, but really they should be doing better. And I think part of the problem, at least in public hospitals like us, is that the process of upgrading PACS is so time consuming, so expensive, so hard to put the business case or whatever through it, that realistically most hospitals that I know of, I mean, I don't remember ever being in a hospital that actually changed PACS. We've had the same one for over a decade. All the hospitals I know of basically stick with the one they've got and they just do upgrades. In fact, I was looking through my email about a PACS upgrade that we've had recently that said, when this upgrade goes through and it doesn't fix the things that we've been complaining about, at some point, are we going to say this isn't good enough and we should change PACS? Or are we just destined to live with this PACS forever? And then I looked at the date and it was July 5th, 2017. And so the same thing happens. And so these companies, there's no good incentive really to create good products, because radiologists, just like you said, are not the ones that actually make the decision in the end. Yeah. So these legacy enterprise-wide companies, the things they optimize for is support and maintenance. So, you know, hospitals like ours really want there to be people on the ground in Australia. So there's no way a US-based company that doesn't have an Australian branch to come into the hospital and train you up is ever going to get a ticket. They obviously go big on cost. And they all know this, so they lock you in with all other add-ons and like, oh, your teaching file is now with you, so getting it across, that's an extra 100,000 to export your teaching file or something. And the result is the tool that we use, the radiologist tool, which is, it's like scalpel and scissors and tweezers for surgeons. This is the thing we use, are so bad by and large. You then go online and you think of the software that we use to record this podcast or our streaming, and you look at how clever it is and how quickly the upgrades come out and how much it is optimized for the people using it. Yeah. And then you go and try and treat or diagnose cancer, and you have to use a thing that just makes you want to headbutt the monitor in frustration. I think we really underestimate how important these tools are to not just how we do our job, but how we feel about doing our job.
Mm.
And I
Yep.
think IT is right up at the top reason why people get burnt out and disillusioned, particularly in the public sector where upgrading and changing is so much harder. You end up hating everything to do with your hospital as a result, like by
Yeah.
extension, because of this terrible experience that you have.
Yeah, it's like I could take the DICOM and put it into a free DICOM viewer on my own computer, and it would do a way better job than the packs
Same with
that I've
voice
got at work.
recognition.
Yeah.
I could dictate into ChatGPT or even Siri and get a better job than the thing that I have to dictate at work.
Anyway, I apologize for my rant and triggering your own rant. A couple of other quick things. I mean, I heard a lot of classic Gaylord in that discussion there. Chiarians, pineal cyst type things, which we've covered many times on the podcast, so I'll leave those out. But the idea of, is there someone else who is going to see it, being something that influences whether you mention a finding in the report, is something I don't think we've mentioned in a while, at least. And I 100% think about when I'm reporting my cases. There are so many reports I read where the radiologist has ignored a big obvious, for example, vertebral hemangioma, which are benign and nothing to worry about. But then the clinician inevitably looks at the scan themselves and goes, oh no, the radiologist has missed all these metastases, and it causes confusion. They may even show the images to the patient, and then the patient sees it and there's more confusion. It's one of those things where I think, yes, please, if there's an obvious, even benign finding, make sure you communicate it in your report if people are going to see it. But be clear that it's benign and incidental. You're just going to save so many people a lot of hassle if you do that. And also interruptions. People aren't going to have to interrupt you and go, oh, excuse me, I think you might have missed these vertebral lesions.
Yes.
I will say, though, if it's the thyroid, bury that sucker in the body of your report. Keep it well out of the conclusion most of the time, I reckon. Anyway, I must have had a strong coffee this morning, Gaylord, because I'm ranting.
Oh, I love it. For once, it's not just me ranting. Go on. What else? Do you have anything else that you want to get off your chest?
Yeah, well, a couple of quick things here. So going backwards on time-resolved MRI angiograms, why did it take me until age 44 to hear this one? I've never heard that. I'm looking forward to testing it out. Yeah. Scrolling backwards through thousands of venous images to get to it. That's going to be great.
Well, the going backwards is a thing that I picked up, or it was just standard when you do catheter angiography, because to pick up shunting, it's really helpful. And believe it or not, when I was a youngster, Dixon, I did a lot of diagnostic angiography. In fact, when I was a first-year registrar, it was in an era that our hospital and then the neurosurgeons specifically were doing ultra-aggressive early clipping following subarachnoid hemorrhage. The theory was, and I don't think anyone does this really anymore, at least not in our hospital, that the rebleed risk was so high in the first 12 hours post the first bleed that you really needed to get in there and clip it. And so in the same way as we do clot retrieval now, where there was a real push to get patients from presentation to the cath lab and then treated, we did the same thing for cerebral angiography. And so to be able to go on call as a first-year registrar, so you've just started doing your training and you're 6 months in, you had to be able to do a 4-vessel selective catheter angiogram. But the hilarious thing was that you had to do it with supervision. So a consultant had to come in, but the consultants were on general rotation. It wasn't the neurointerventionalist or the interventionist. So they have all these memories of like the breast radiologist at 3 a.m. having to come in and sit in the angio suite while I faff about as a first year doing a 4-vessel angiogram. And they're sitting there saying, if I'm struggling to get into the groin or something, it's like, you're on your own, buddy.
You're on your own.
I don't know why I'm here. I want to be in bed.
Gosh.
And so we did, when we were on call, we would do every second night on call that we were on, you'd be doing a 4-vessel angiogram in the middle of the night on your own as a first year. So
I wouldn't want to see the DWI on the very next day after those 4-vessel angiograms.
Never do that. But no, going backwards works just as well on time-resolved MRA, although, time-resolved MRA, MRV is just not a great test overall.
No, it's interesting. You just always assume because physiologically it goes from arterial then to venous that you just follow it that way. But of course you can go backwards. I just had never ever thought of it that way. but I'll give it a go and I'll report back.
Yes, please. Do.
Finally, you mentioned textbook and journal versus what you see in reality, which I think for relatively new imaging techniques is definitely something that we really need to remember. I don't want to spoil anything here, Gaylad, but did you know that some of the vendors fund the researchers who publish papers showing these amazingly beautiful and clear-cut cases? Did you know that? The actual real-world reality is why panel discussions and podcasts with radiologists telling it how it is, why they are so important, I reckon. I'm done. That's it. My rant's over.
Vendors funding research and textbook publications to include unrealistically pretty pictures. You shock me, Dixon. Really?
We break the big stories here.
Never. Really? In fact, without even cherry picking the best examples of a whole bunch of cases that you might do, the very fact that textbooks and journal articles publish one image from the whole stack is not only also cherry picking, because often you'll pick the image that looks the prettiest, but I think from a teaching point of view, it's really misleading because it sort of suggests that knowing which is the image is obvious. You have a whole stack going through a tumor, say, or through some kind of abnormality, and which is the one that you should believe is representative of the whole pathology is not obvious, and that's part of what you have to learn. And I don't understand why in this day and age where most journals are now purely online, why aren't they coming to us and saying, hey, we want all our articles that have images, the authors have to upload the full case to Radiopedia or to their own repository or to whatever, and then we'll pick a key image to show it, but then you can go and look at the whole thing. I don't understand why we're not doing this. I think it's terrible. I think there's probably lots of wrong incentives at play. And if you're running a journal, write to us. We will help you do a better job. Anyway, I'm sorry. You've riled me up as well. I'm going to go and have a nap and a bit of a calm down.
It's contagious.
And
it's contagious today.
Little belly rub.
All right, it might be time to wrap up this episode then, Gaylad, so you can go get your belly rub. How can people get in contact with us?
Well, you can email us at podcast@radiopedia.org with any ideas or feedbacks or complaints or meat-related stories or whatever. And you can also join the Radiopedia community at large in our chat by visiting radiopedia.org/community.
Yeah, or you could even come up to us at conferences or events, because you were telling me yesterday that quite a few people sought you out at a recent one, Gaylad.
Yes. I was invited to speak at the Medical Student Society Conference here in Melbourne, which is a student-led, student-convened, student-run, student-organised event for the University of Melbourne medical students. It's a big event. It was at the Melbourne Convention Centre down by the river. Anyway, I had a session all to myself. I was asked to speak about the history of Radiopedia, and then that was followed by a Ask Me Anything Q&A session for about 45 minutes or so. And it was actually really good fun. The room was full. There were people standing at the back. There was a really lovely vibe, a lot of engagement, people nodding while I was ranting about, textbooks and various other things that got me riled up. And after the session, I hung out and a few dozen students came up to have a chat. And some wanted to ask advice on how to get into radiology. Some wanted to know how to get involved into Radiopedia. And if you're interested, just go to radiopedia.org/chat and say hi. Anyway, a bunch of them just wanted to say thank you for Radiopedia because it really helps them out. But a number of them actually mentioned that they listened to this little podcast. And one even said that this podcast played a role in him deciding to do medicine. So he was doing his undergraduate, like a science course or something, and was deciding whether to pursue medicine as the next thing or not. And so he was doing a bit of research into what this whole medicine thing was about and came across our podcast. And we didn't scare him away. In fact, we played a small role. So
he thought, I'd like to be a Muppet like them.
Yeah, that's right. I hope the profession won't disappoint. Don't hold us to it, though. You never know. But to all the medical students out there who are listening, a big hello. It was wonderful to see you all there.
All right. And if you want to help support Radiopedia, then you can become a paid supporter via the website or purchase an all-access pass to our online courses and conference. In doing so, you'll be helping us to give free course and conference access to people in 125 low and middle income countries. I've already plugged the conference up top. Everyone's going to register and join us there. And what else can people do to help us out, Frank?
You can also help us out by leaving a 5-star review in the podcast app of your choosing. We're not telling you which one to use. You can pick, but you have to give us 5 stars.
Yeah, but I can tell by looking at the stats, most people pick the Apple one or the Spotify one.
Yeah.
So, yeah, definitely. And on the Spotify, I don't even think you can give reviews. You can just give 5 stars. So maybe jump on the Apple one and give us an actual text review. That'd be awesome. And we'll catch you all again sometime soon in the reading room.
Stay angry and stay rad.
I like it. I like it. And don't forget to send me some of that fake quail Fagua Gala. Track it down.
Well, they don't sell it online. I was all ready to buy a pack and have it delivered, but you have to go to restaurants, and I can't find a restaurant yet. But as soon as I do, we'll go and have a dinner there, and we'll pork up.
We'll pork up. Sounds awesome. All right. See you in a couple of weeks, Caleb.
See you, Dixon. Bye-bye.
Bye.